Hello everyone and welcome to the oral rehabilitation case presentation. The oral rehabilitation case is something that's required of all senior students in their last quarter of dental school to present on one case where they really had multiple disciplines and they kind of took all the way through. And so this is the case that I chose. And the reason I chose this case is it's very near and dear to me because I really got to collaborate with so many different departments at our school. I really want to give huge acknowledgments to Dr. Mana Naeem, the treating orthodontic resident, who has been so exemplary in her professionalism, her leadership, and just overall, compassion towards myself and most importantly, our shared patients. So, Dr. Mana Naeem, if you're watching this, I really do appreciate everything that you've done. And for the orthodontic faculty, I know that they are so proud of you, and so is our school. So thank you, Dr. Naeem, and I hope all of you enjoy this case. So this case is a 23-year-old female, and she works locally in San Francisco, and her medical history is non-contributory, but she does smoke and drink alcohol regularly. Now, this is a patient that I met and really wanted to bring into the school to become our patient, or my patient, but she always had a difficult time doing that. And we actually had multiple appointments where she wasn't able to make them, kind of canceled last minute. But of course, we stayed friendly, and I actually got a call from her on Monday morning. She said that she went out on Sunday, woke up in the hospital, and that she had bruises on her face and broken teeth and didn't know what happened. So we were able to see the patient the next day. So she had the trauma on Sunday, woke up on Monday, and then we saw her on Tuesday. And this here is a picture of how she presented to us on Tuesday. And we have many pictures at the end of this presentation, so stick around for those pictures. And again, her chief concern was I went out to a party, woke up in the hospital, have not been to a dentist in many years. I want to get the work that I needed done. And she was interested ultimately in orthodontics and kind of just improving, her teeth as well as just her lifestyle. I think this was a really big wake up call for her. And what we really did is we really kind of just aided her and were, all of us professionals in terms of just letting her express her fears and kind of guide her and making necessary changes that she wanted to in her life. And I think we got an excellent result. You'll see where we're at towards the end of this presentation. So here's the FMX that we took. The first appointment on Tuesday, all we did was take impressions, so I could make her an Essex or little stay plate, and sorry, just an Essex retainer, and then and then we move forward from there. And also I took these radiographs. So here you see that number 7 actually had a horizontal fracture. It was deemed non-restorable. And then here we actually have 2 supernumerary teeth which really come into play, especially this one on the right. And the way we named them was 70 and 78 because by insurance purposes, the way that you name a supernumerary tooth is you just add 50 to the number tooth that it is next to. So this one was tooth number 20. And so if we had 50, that would mean that this supernumerary tooth is number 70, and this here we called 78. And so here's a Pena reconstruction from the CBCT volume that was taken during her orthodontic consultation. Again, a lot of the imaging here is provided by the Graduate Orthodontic Clinic, for they took a lot of this imaging. So again, compliments to the entire orthodontic clinic. Thank you for being so transparent and giving us all the information that we needed. So thank you. And here we can see clearly this was in between appointments, so she already had number 70 out. And here you can see that number 78, which was really, really close. We measured actually at 0.6 millimeters away from the right mental foramen. So we had lots of discussions with the patient, and we'll get into those a little bit later. Here, just from that same CBCT volume, you can see again we freshly extracted tooth number 70, right? And then here, this is tooth number 78 on the patient's right side. And here you can see right in between the roots here. And again, just another angle of how close that really was. And then just another lateral ceph where you can see that tooth right here, right next to that mental foramen. So we won't get too far into the lateral cephalometric analysis, but we do have this here because there is something that we want to definitely take a look at. For perio or perio condition, you can see there's lots of bleeding on probing when she first presented with many 4s, 5s, 6s. And a lot of that was consistent with just not being to a dentist in a while. We know that with smokers, typically they present with less bleeding on probing, but actually this was not her case at all. She was about 80% of the entire mouth was bleeding on probing. And so we reached the periodontal diagnosis of generalized chronic gingivitis with localized chronic mild periodontitis in the regions of the maxillary and mandibular premolars, with the primary etiology of bacterial plaque and secondary etiology of malocclusion, with the prognosis good for all remaining dentition, assuming that there was improved oral hygiene and necessary scaling and root planing, which we'll talk about in a little bit. And here, this is at the ITE. You can see that there is much better pocket readings. Yeah, we still have some deep pockets, and there still is some bleeding on probing, especially in the posteriors, but a far improvement. And we actually did refine the SRP a little bit since we had, now the swelling was gone and the gums relaxed a little bit. And so we did refine the SRP, and after refinement, working with the periodontist, we decided that the patient was suitable from a periodontal standpoint for receiving orthodontic therapy. So Carrie's risk assessment, she had a pH of 5.9, an ATP meter reading of 4324, which we know that we like the ATP meter reading to be under 1500, as well as we just found some active decay with mild to moderate restorative history. Overall, her Carrie's risk was high, and due to what we looked at and everything we saw, we thought the prognosis was good with restorative treatment and just behavioral, at home oral hygiene changes. Overall, her risk assessment, we said the etiologies for disease were poor oral hygiene, just a lack of dental knowledge, high caries risk, the malocclusion, and her the fact that she's a smoker. But nonetheless, with good patient compliance and improved oral hygiene, we said that the prognosis was good. So the ideal treatment plan and the treatment plan options really kind of revolve around tooth number 7. We didn't see any need for any fixed work. But we knew we needed some oral surgery, and again, the patient did express high interest in wanting orthodontics. The patient really did not like the idea of an implant. She said she has many friends and family of implants, and that they've always had issues with them, and that if we could come up with a solution that avoided the use of implants, she was highly interested in doing so. So what we did is urgent care. We extracted tooth number 7, which was causing her pain, and delivered the S6 retainer that I fabricated. Disease control, which is oral hygiene instruction, as always, is our first thing. And then scaling and root planing on the lower left and right quadrants. Initial therapy evaluation for 8 weeks post-operative. And so after the initial therapy evaluation, we were looking to do direct restorations on number 3, 14, 15, 17, 18, 19, and then a separate buccal class 5 on number 19 with the number 9 class 4. And then a reconstructive phase of extraction on number 10, 21, 28, and then the 2 supernumerary teeth, 70 and 78, followed by comprehensive orthodontic treatment for both arches, and then just aesthetic recontouring of maxillary anterior teeth with supportive periodontal therapy 4 months after SRP. And then again, we do have the asterisk because this is what the patient ultimately wanted. And really, our different treatment plan alternatives really focus around how we would replace number 7, like we mentioned. So first, we talked about an implant. Again, patient was not a fan of the implant, did not want to pursue any implant dentistry. And then so we said, okay, well, we could do no orthodontics and just go straight to the implant. Patient did not want that. And then we talked about the idea of no ortho and just doing a fixed dental prosthesis. And the patient also did not look into that. And so we ended up, like I said, going with the bilateral canine substitution. And just to go back really quick, that's why you see number 10, because again, we were looking to make her symmetric, so be a dentulous in the maxillary lateral incisor position at number 7 and on 10 on the left and right sides. And so this again is pictures from presentation. Here you can see that she has the lesion from her lip when she fell. Tooth number 7, fractured Ellis class 3, and then a simple Ellis fracture class 1 here on number 9. Then you can just see some gingival inflammation, like we talked about, consistent with not seeing a dentist in many years. And then, you can just see some calculus here on the teeth. and a little bit of active decay, which you'll see better pictures on back here. But overall, this is where we were. So again, we took impressions and radiographs, and then 2 days later, again, she first saw me on Tuesday. We saw her on that Thursday. I delivered this Essex retainer that she could wear. That way, when she was going out about, she didn't look like she was having a missing tooth. I thought the shade was actually pretty spot on. We used actually B1 shade here. And if I was to do it again, I think that I cut it maybe a little bit too short. You can clearly see this line here. Patient loved it. I think if I would have had a little bit more time, I think I could have delivered a little bit more of an aesthetic Essex retainer. But nonetheless, patient was happy with it, and that's what we went with. And I think she wore that pretty well, actually. She wore this Essex for about 5 months before she initiated orthodontic treatment. And here, this is a picture at our third visit. There was about 2.5 months she's had this Essex retainer at this point. Remember, this is a patient who was not regularly brushing or flossing, and I just put this picture up to show how clean she actually kept her Essex retainer, which really showed that she was really paying attention to what we were talking about oral hygiene and just improving her home regimen. So here, again, we did number 3, occlusal lingual, number 14, occlusal lingual, number 15, occlusal, 17, 18, 19, occlusal, and 19, buccal class 5. And we did all 4 of these restorations in one appointment and these 3 in one appointment. So a little bit of quadrant dentistry here. And then here, this is at the SRP. So if I was to go back just one slide here, you can kind of see how she had the calculus formation. Just another quick point of why we take pictures. Patient, we really want to show where the disease was, and where she could, clean better. And that way she had this kind of to reference. Again, here you can see a little bit more of that active decay on those teeth. Here you can see that class 5 area, and a little bit better on those teeth that had recurrent decay. Here, this is the class 4 restoration. We have it from all angles. And then here I have before and after. So again, this was that presentation date, and this is right when we completed the class 4. Patient was ecstatic with this. I was very happy. I think this was probably the best thing I did up to that point in the main clinic. And, just a lot of things to look at here. So I think, the symmetry here looks really sharp. We know we have a line angle here, and that's where we want light to reflect off of the mesial line angle. And we have almost that exactly. Here we have, maybe a little bit larger of an incisal abrasion than I would have liked, but really looking at the symmetry, I think it looked pretty good actually. And again, this is about 2-3 months post-operative of extraction of 7, so she showed great healing. And not only that, too, you can clearly see that her periodontal condition has really improved. You can see much more stippling and much more of a coral pink appearance, just more indicative of health. And again, just another way of showing not only the teeth, but as well as the gums for the patient in order to keep her motivated and keep her going with upkeeping really good oral hygiene. So here, just so we took some pictures after finishing the class 4, just of the whole case. Sorry you have these blown out images. It's really hard to tell. This is just a PowerPoint file saving error here. But again, we have the restorations here, like we talked about. We did the quadrant dentistry, 17 to 19, and it looks far better than it did, and we were really happy with it. And then again, another reason to take the picture is you see here, she already has some formation of some calculus that we did talk to the patient about, and kind of just reinforce that she needs to be cleaning really diligently there. Here, this is a couple of days or about a week or so post-operative where we did attempt the oral surgery graduate clinic to remove both supernumeraries number 70 and number 78. You'll see that they were successful in taking out number 70, but 78, while the crown of 78 was exposed, the oral surgery resident attending oral surgery faculty recommended that we actually did get CBCT imaging, which we did not have at that point before we ended up extracting that tooth, which ultimately came to our benefit and the patient's benefit. So you'll see that we took on that later. So here, this is a really important picture and why, kind of rationale as to why we went with doing the bilateral canine substitution. So I promised I wouldn't get too far into the weeds here with the orthodontics, but just to kind of touch on it, right? The patient was diagnosed with skeletal class 1, but then class 3 tendency dental. That's why you have the edge-to-edge occlusion. And what you'll see is if you look at the shape of the lip, you can actually see that she has an incompetent lip closure. And we really have too far of an angle here. So if we kind of overlay that CBCT tracing, and again, sorry we can't see all of it. We're just protecting the patient's privacy here. But what you'll see is you'll see that when we look at the B line, right, and then we look at this angle here, right, to L1, L1 being the lower number 1 or lower central incisor, you'll see that this angulation right here is about a 35 degrees, 35 or 37 near CBCT, and the average is actually about a 25, meaning that the tooth actually should be stood farther up, as well as you see that class 3 tendency all the way through in the molars here. And so what the plan was, is since we were doing the bilateral canine substitution, we knew that we were going to move all of the teeth here backward, or excuse me, all the maxillary teeth forward, and then by taking advantage of pulling the first premolars, we're actually going to move and upright the lower teeth. And so by doing that, right, we were going to get that really nice class 1. And so that's why the bilateral canine substitution worked, because we actually needed to reduce space anyway to get the patient out of the, class 3 or edge-to-edge occlusion. So here again, just mirroring that line, we can see that we have that same angulation brought out, which is a parallel line here, and we know that we want to be a little bit more upright and have more of a competent lip closure. So here, this is, again, compliments to Dr. Mana Naeem in the Graduate Ortho Clinic using their scanners. This is where the patient was at our orthodontic consultation, and just to kind of reiterate, give ourselves another view, the treatment plan here is to move the canines into the lateral space. So that would be at our next appointment and working with the oral surgery resident clinic, we're going to extract 10, number 21, number 28, so the first lower premolars, right? And then also that tooth number 78, which is buried down here, right? And the idea is, imagine this tooth is gone, is for all of these teeth to come forward and assume the position of the tooth mesial to them. And so, right, how do we get that from there into where we want to go? So here, this is the pictures taken by Dr. Mana Naeem in the Graduate Ortho Clinic. You can kind of see at the consultation where they did talk about everything we talked about. And you can even see too, this is a really good picture showing that, we really want this line to be, pretty straight. And you can actually see that she's actually pretty far out, anteriorly, if you will, here on the face. And so we know we had room to kind of come posteriorly to give her kind of a more natural and straight smile line. But one really neat thing, and kind of something for all general, dentists or students that are looking to be general dentists to focus on is, our work stays with us, right? And we own that work. So remember, we talked about the restorations we did. So here's number 3, OL. Really hard to tell that there's restoration there. Number 14, OL, and number 15, occlusal, same thing. And then again, we did 17, 18, 19, and 19 buccal all in one appointment. And again, I think they look great. No recurrent decay. This is about 3 months post-operative, and things look really good, including her, periodontal condition, which she was doing a great job brushing and flossing. So what we did is we coordinated with the oral surgery resident clinic as well as the orthodontic resident clinic to where we wanted to extract the, again, tooth number 10, 21, 28, and the supernumerary 78 all at one appointment. And then immediately after that, in the Graduate Orthodontic Clinic, Dr. Mana Naeem actually fabricated a stay plate for the patient to wear to close the number 7 and number 10 edentulous areas. And in doing so, this is 4 days post-operative. You'll see that there was some iatrogenic damage by the operator when they extracted number 10. So all we showed here is just me. I saw the patient as quick as we could, just to kind of give her a patch on the composite. So here you can see that class 4 add to number 9 here. And again, just a before and after of when she came, and then we patched up with the composite. Now, if I were to be critical, I think I could have blended this a little bit more. I would have done so by just beveling. I did do a bevel, but I don't think maybe I was a little too shy in the bevel. So, but nonetheless, the patient was happy with the outcome, and so was I. And then here, this is, that same appointment right after I finished. We took more pictures. Here, she's currently wearing the stay plate, actually, that they delivered. I think it looks great. I think the color match was really good. The shape is really nice. right? And this is something that actually you'll see in the pictures later. She's actually able to wear this under her full metal braces. And so again, just showing the healing sites and everything. And if you were wondering, we did get out tooth number 78, which was necessary because if we didn't get that tooth out, there's no way we would have been able to have any orthodontic treatment here because it would have run into the roots of these teeth here. But we were able to do it with no iatrogenic damage to the mental foramen, and patient reported absolutely zero signs of any postoperative paresthesia or sensitivity. So definitely a huge win, and compliments to the oral surgery resident. Here, this is at her banding for her braces in the graduate ortho clinic. Again, compliments Dr. Naeem. Here you see this is the stay plate that they delivered. And here you see the braces on, and this is the patient in them. And again, you'll see the next picture of her actually wearing the stay plate under that. So this is the first appointment. Here, this is at the second appointment, and it was about a month between, and you can already see some really, really nice movement. See some gorgeous healing here at the number 10 site, as well as the premolar sites. And, you have this little indentation where that tooth used to be. But again, really nice healing. You can already see some, really good straightening of the lower teeth here. And then at her last appointment, I believe it was March 5th, right before the school closure due to COVID-19, you can see the updates. And this is actually her wearing her stay plate that was fabricated while she's wearing the braces. So really, she's not going around with these huge spaces in the anterior that we thought about. It actually looks pretty good, and I think it's a really elegant design. And again, just to touch on, we can't run from our work. Here's the restorations that we did, or that I did in the main clinic. You can see that they're all holding up really nicely, and I'm just really happy with the way they turned out. So, kind of touching on some research here. Now, bilateral canine substitution, most often, if it's done in the literature, is due to, just congenital missing lateral canines. And so here, this was a patient in the literature they talked about. Patient was born with congenitally missing lateral canines, and when she was a child, her orthodontist actually did bilateral canine substitution, and her general dentist just added some composite on the canines. So these are the canines here. And you can see that the color match isn't really great. The midline was completely off. And so what they did was they, redid the orthodontics, and then they actually fabricated some brand new veneers. And you can see it's just an absolute beauty of, result that they got. And the authors actually included this picture to kind of show this is, your average canine here, and then this orange is your, average outline for a lateral incisor, right? So these two right here in the lateral incisor, these are actually canine. These are the patient's canines, and these are actually, the patient's first premolar, and so on and so forth. And if you look at it, I think it looks extremely natural. I mean, they weren't able to completely correct the midline, but when you look at before and after, this is something that we really hope to see our patient look like in the next couple of years, and have just a great result with that. So again, there's mixed reviews about bilateral canine substitution. I know some of the restorative faculty were wary on it, and even some orthodontists are wary on it. But again, given all the factors and geometrical, biological factors we talked about, we decided that this patient was an absolute home run for this type of treatment, and especially respecting her wishes of not wanting to go with an implant in the anterior region. So overall, this is the works cited, and then that really concludes the oral rehabilitation project. Again, I just want to say thank you to all three departments, being the main clinic, the graduate orthodontic clinic, and the graduate oral surgery clinic, for all of your teamwork, wisdom, and guidance ultimately came and just for the patient's benefit. And I can tell you that the patient is absolutely ecstatic and doing better than she has ever done. So again, thank you. And I really hope that you've been enjoying the portfolio so far. As always, you have the slides for this exact presentation we just went over directly under this, and it's available for you to check out at your leisure. So if you have any questions, please feel free to email at underscore Barnett, Barnett, at u.pacific.edu, and I'll be happy to answer your questions. Thank you so much.